what we all must learn to do. You and you and you and you. Duck and cover.
Be sure and remember what Bert the Turtle just did, friends, because every one of us must remember to do the same thing. That's what this film is all about. Duck and cover, just as you do in your school. We all know the atomic bomb is very dangerous. There is a bright flash, brighter than the sun, brighter than anything you've ever seen. And then you cover. And very tightly, you cover the back of your neck and your face. It's a bomb. Duck and cover. Paul and Patty know what to do. Paul covered the back of his head so that he wouldn't be burned. And Patty covered herself with the coat she was carrying. Duck and cover. Don't wait. Duck away from the windows fast. The glass may break and fly through the air and cut you.
Remember what to do, friends. Now tell me right out loud. What are you supposed to do when you see the flash?
Duck and cover. Duck and cover. Duck and cover.
Well, Bert the Turtle's ready, and the kids in the film seem prepared, but on a much more serious note, are we ready to protect our children in the event of a disaster? Who am I? I'm Josh Claypo from the South Central Center for Public Health Preparedness, and we're going to explore this serious question in today's broadcast. In the next hour, we're going to ask our panel of experts to help us understand how prepared our system is to deal with pediatric emergencies and what we need to do to assure that pediatric casualties are not the result of a lack of preparedness. With us today are Dr. Tony Farguson, Medical Director and Vice President of Clinical Affairs for Children's Health System of Alabama, Dr. Cardin Johnson, Chair of the Disaster Preparedness Team and immediate past President of the American Academy of Pediatrics, and Dr. Martha Wingate, Assistant Professor in the Department of Healthcare Organization and Policy at the University of Alabama at Birmingham School of Public Health. We have a lot to cover in the next hour, but let me briefly tell you about the broadcast series. Our broadcasts are produced by the South Central Center in collaboration with the Alabama Department of Public Health. The South Central Center is a partnership of the state and local health departments of Alabama, Arkansas, Louisiana, and Mississippi, and the schools of public health at the University of Alabama at Birmingham, Tulane University, and the University of Arkansas for Medical Sciences. The center is designed to prepare the workforce to respond to public health threats and emergencies by providing training opportunities, and funding for the center comes from the CDC. Now, if you'd like more information about the center, you can visit the webpage that you see on your screen. Later in the broadcast, you're going to have a chance to talk with our guests today. So throughout the program, you will see our 800 number and email address up on the screen. And please feel free to call or email any questions or comments that you may have. You can also register for the program and receive handouts and evaluation forms from the ADPH website. Okay, let's get started. Welcome, everybody.
Good to be here.
Thank you.
Good to have you. What I like to do when I start the broadcast is to start everybody out by kind of giving the take-home message in the beginning. And so, Martha, we're going to pick on you first. What do you hope folks get out of the broadcast today?
I think overall, I'd like to add my hope that we'll be able to communicate as that children's needs are integral when we talk about emergency preparedness, when we talk about planning, response, and recovery, and seeing children as an integral part of all components of emergency preparedness.
Okay, good.
I don't know if I can improve on that or not, but my goal is to emphasize children and make sure that children are included in preparation and response and follow-up. But there's another segment that I'll probably put into there as well I consider very important, and that is not only for the public response, the federally funded response, but also the private sector. It's got to be part of this inclusion. So,
okay.
Children, public and private.
Good. Ferguson.
From my point of view, I think when we're talking about kids and care for kids, we need a system that regionalizes care quicker in some situations than we see with adults in trauma and disaster situations. And that's what I'm particularly interested in. When to regionalize care for kids, how to do that in a more sophisticated way.
Okay.
Very important.
I guess, Martha, maybe you can help us sort of set the stage a little bit. I mean, we're talking about kids and children, but from a public health perspective, what does kids mean,
Right.
and how many of them are there, and what are we talking about with regard to our healthcare delivery systems?
So just the basic demographics. There's about, we were debating this a minute ago, there's about 300 million people in the United States. And of that, about 73.3 million are under the age of 18. So about 25% of the population in the United States is under the age of 18. And we're looking at about 18% of that being school-age children. And that is between the ages of 5 and 17. So we've got a lot of kids that are in places outside of the home, and even our under 5 population as well, and that's about 7%. So we've got a good portion of the population that we really are talking about today.
Well, I was thinking, and I don't know if this is more to you or Cardin, this idea of why are they special? I mean, they're special for all of us because they're our future, et cetera, but I guess more from a clinical standpoint, what makes them particularly vulnerable?
Children, I think, are the most important segment of our society. They, like Martha was saying, they represent 25% of the population, but when you think of the future, they're 100% of the future. So when you start saying we need to specialize and take care of children's issues, then there's the other arguments that come up. Yeah, we got to take care of children, but what about the elderly? What about the mentally handicapped? What about the others? And so the pregnant people, the disabled, and all those have arguments. But my argument is that children are extremely special, and they are the most important segment of society, and they should be separated out. Now, how do they get different? Well, we think of that in several different categories: knowledge, skills, attitude, and equipment. And the knowledge is probably the easiest to get by, and we already know a lot of things, and that is that the flu attack rate in adolescence is higher than it is in other parts. Now, the ones who get admitted most to hospital are the infants and the elderly. The radiation exposure, which we've had on this show before, mostly attacks children less than 5. Their rates of thyroid cancer are much higher. Some of the gases settle, and so the children are smaller, and so they're walking around in the gas, and they may pass out before the adults do, and get into problems. We know that during following Hiroshima, that the girls who were developing breast at that time, the adolescents, had a higher incidence of breast cancer later on than did the girls who were not developing breast or who already had breast developed. So children are special with knowledge issues, and even all the normal children. You say that children's not more vulnerable, but children have a higher basal metabolic rate. They have a faster respiratory rate, so they're breathing faster. Working in the emergency department at Children's, I can see kids who come in with carbon monoxide poisoning, and that kid will pass out and go unconscious, and other people in the room may just be minimally affected. And so there's a difference in children's responses to different toxins. So that's very different. Can I go on?
Sure.
All right, and then skills. And we know that, and people who do rescue and public health know that the skills in cardiopulmonary resuscitation are different. So you have to go at different rates and different ways. Choking child is different than a choking adult. So they are different. And then the skills that the nurses have to have and the healthcare providers have to have with starting IVs, taking care of a child, is different. Now, equipment.
I can imagine.
We've gone through this phase of having big blood pressure cuffs available for everybody, and so you put down this 3-pound kid and you put the big blood pressure cuff on him. So I think we're getting better with that, but endotracheal tubes are bigger, and that's what separates, I think, out the children's hospitals from other hospitals, is they have a whole series of equipment up there, from a 2-pound baby to a 250-pound adolescent or 300-pound adolescent, and we have to be able to take care of them. But the strategic national stockpile didn't have enough diapers on it, or didn't have the formula and medications for children, designed for children. So those were things that were missing. But the most important segment, I think, is attitude. And it takes someone who's used to dealing with children. You have to be prepared to deal with children so that you can approach them in emergency. All of our EMS people and all of those working in emergency department have approached a child, and the thought hits your brain, is that my child? Right. And so then you freeze. And so you have to have the attitude of getting over that, so then you can now provide compassion to that child, care to that child, and be able to take care of them. So those are some of the reasons I think that we really should separate out children and emphasize them as we talk about disaster preparedness.
Well, and the question, I was going to leap up, maybe.
Well, I'd just like to go back to your the opening segment, the duck and cover video, and use that to highlight two other issues. One is the unique psychosocial needs of kids, and one of the reasons we find, those of us who were raised in a duck and cover era, find that video kind of amusing is that it's a classic example of anxiety creating public awareness campaign that we never really used. And so kids are uniquely vulnerable. They have a lot of their thought process is different, and so we have to be careful of the false positive kind of anxiety we perpetuate on our communities of kids as well. And the other thing that was highlighted in that video, I think, is the unique environmental vulnerability of kids. They're in soft target environments, or in schools, which are uniquely vulnerable to terrorist threats, I believe, as the Russian experience shows, and also those environments, because they group kids in large numbers, are uniquely vulnerable from some of the infectious disease hazards such as flu that we've been talking about. So those two elements, in addition to Cardin's, I think, suggest that we ought to think differently about kids.
Well, I mean, that kind of leads me to the next question. We talk about, so that we know that the kids are different. What about the healthcare system for kids? I mean, just as to start us off, how is it different than the adult system?
Well, I think it's important to look at kind of the numerator and denominator. If I can, I'll split it into those two categories. So the numerator would be sick people, and the denominator is the base population. So the pediatric population is different in adults because the numerator relative to the denominator is smaller. There's relatively fewer sick kids than compared to the population base compared to adults. Right. And that has some implications for the delivery system. So the delivery system for kids is not as large and extensive as adults. Most of the diseases kids get are relatively straightforward, so a lot of the care is taken care of in hospitals that are multifunctional, take care of adults as well. But there's a small segment, maybe 5% of the pediatric population, that has very specific healthcare needs, and those needs are often met in regional centers of excellence, and those are geographically relatively dispersed throughout the country. And because of some idiosyncrasies in funding and whatnot, they're relatively small in terms they function at near capacity in almost all parts of the country. So there's not a lot of surge capacity in those facilities. So that's the numerator. The other interesting thing about pediatrics is the denominator. It's relatively large, but only 10% or so of kids contact beyond the primary care health system in a given year. So as we talked about earlier, the system's relatively small for inpatient or sick child care. But when we talk about a disaster event, all of a sudden that entire denominator becomes vulnerable and is uniquely vulnerable in certain ways. So we expect a proportionately, at least as much or if not greater, impact on kids in a lot of these disasters than we do on adults. So those are the kind of two unique aspects of the pediatric system that make it different than adult care.
So among other things, this idea of surge capacity is a particularly strong vulnerability for the system, and from the way you've described it.
I think so. I mean, from my point of view, it's most of the plans. I'll just step back. Most disaster plans tend to look at populations as populations, and they don't segment them so nicely into buckets. In the pediatric subpopulation, I think the surge capacity is a particular issue. Add to that the fact that in most
when you talk about surge capacity, you're talking about hospitalized surge?
Any aspect of care, I think. It's not just hospital care. I think the outpatient care as well, but the hospital care and outpatient specialized care is uniquely vulnerable. But I do think even in the primary care systems, and I'll point, my reason for saying that is we tend to, again, look at care going on in disaster the same way it goes on now, where kids present as individual units to the care networks they're going to. But most people believe that in a disaster they're going to present to pediatric providers as family units, and that those providers are going to be subjected to the entire, subjected is not the right word, but they're going to have some plan to care for entire family units rather than just individual children. So that is going to also put an increasing demand on pediatric facilities or facilities that care for kids.
And I think also, just to please agree, disagree, but I think particularly in this part of the country, in the southeast, we're a little bit unique as opposed to in the northeast, where our pediatric capabilities are a little more spread out too, which could potentially affect the care provision.
Well, I mean, we have to distinguish between primary and certainly in a state like Alabama, you have a lot of rural care environments, and you have a lot of poverty that also, I know we'll touch on that later, accentuates the problem. But even in large metropolitan areas, if you look at the density of sophisticated pediatric providers, coordinary care pediatric providers are relatively sparse compared to adult facilities, no doubt about it.
Let's go down from the sort of system level. I was thinking, Katrina being the most prominent that we've been talking about. When the disaster strikes, pediatric primary care providers who are in the outpatient setting, what are they dealing with? I mean, we unfortunately we've been able to look at that and we can understand. But can you talk a little bit about specifics that they're going to deal with or have dealt with when that population surge occurs?
When we look back on previous disasters, we look on the Edward Murrah building in Oklahoma City, and we look at the 9/11, we look at the San Francisco earthquake, and we see some dramatic rescues. We see, people with their legs being cut off so they can be rescued, and digging for children for days. But the hospital surge for those was minimal. The response team responded. We had a tornado in Birmingham, and we called it disaster alert, and the response was magnificent. We had 30 children admitted within an hour, and 6 of those were in the operating room. But the team worked. The infrastructure was intact, and so we didn't have to go beyond. And I think that's what Tony's talking about. Let's decide which ones we have to go beyond and use other hospitals, other facilities, and which ones we don't. One of the things that we learned was that within those children with special care needs, that they needed to have some sort of record. And so whether they're in a disaster or not, they need to have at least some minimal information that they can go with. And so the American College of Emergency Physicians and American Academy of Pediatrics have gotten together and formed a sheet that's accepted by both those organizations with just a little bit of stuff that will help in the emergency department, and if they go out of state, if they have this information, would be good to have. And that's perfect for an electronic health record, to have that information on a person.
Now this says for children with special needs, but I would
so if the child who's on dialysis, for instance, or somebody who's on leukemia and is on a protocol, then you have a child with cerebral palsy. Now, can you use this for all children? Yes, but it's kind of nice to have the ones who are utilizing, high utilizers of the healthcare system,
I see what you're saying.
be better educated, and so that's the place to start. And you start with that, and then you go to the others. Now.
I think as long as we're talking about primary care, we should also point out a unique strength of the pediatric delivery system, which is that we have a very large preventative health network that's very used to distributing, for example, vaccines. And in pandemic flu or situations like that, I think that we have some unique assets in the pediatric provider community.
And I think having said that, I think there's some opportunity for the interface between public health, EMA, those typical emergency response agencies that we've seen in Katrina, that we've seen do some wonderful things. We've seen some areas that they can improve upon. How can they interact more closely with the typical pediatric care system?
And I think that's essential, is to have the groups working together. Certainly, as we recognized in Katrina from the people who are hands-on, knowing people beforehand aided tremendously in the rescue efforts afterwards, and when the Katrina hit and the levees were breached. So that brings me to, I'd like to talk about the supplement to pediatrics. This is hot off the press. It's May, this issue, and as opposed to most supplements in pediatrics, this one is available to anybody who wants to read it. So you can go to the website, www.aap.org, and on the opening website comes up a note about this, and you can hot link and pull it up and print it out. And this is stories written by hands-on pediatricians as they were caring for children during disaster and immediate responses. And these are dramatic stories of what the pediatricians have gone through, and there are tremendous lessons learned about what happened and what can be prepared for in the future. So just imagine, Josh, you're sitting there and it's 90 degrees inside your building. It's 90% humidity, and kind of like this. And you don't have any electricity, and you don't have any water, you don't have any sewage, and the building is designed for air conditioning. And all you have is sick children, and you have to take care of them. And you do this for hours and hours and then days and days. And those stories are documented in here. Now you've heard we've all heard about the rescue of the little 2-pound preemie in a canoe. And they had planned for a Fish and Wildlife John boat to come by. And they went downstairs, took the baby downstairs and waited, but the John boat didn't come. So we had communication issues. But some orthopedic residents came by in a canoe and were able to canoe this baby over to safety. But you haven't heard about stories about a neonatologist whose hospital then was closed. The water went out in the basement. And so he had to rescue his 30 neonates and get them out of the city. No communications. How do you do that? So he gets the isolate, and he's got to get it to someplace a helicopter can come. He has to take it to a hole in the wall designed for garbage. And so they take it to the parking deck, roll up to the top of the parking deck, and then take it up some steps. Stand on the parking deck, wave at helicopters going by. Say, please stop and pick me up. For 6 hours with this little baby waiting on a helicopter. Helicopter landed. The pilot said, we can't take your isolate. We can take you and the baby, but not the isolate. So they take off, going out of the disaster area to Baton Rouge. Had to stop for gas. These are things, that are hard to predict, that are well documented in here. And then a pediatrician practicing on the Gulf Coast in Mississippi, talking to the children, and these children have had to leave their home. They were rescued in little ice coolers used for boats and wash tubs and taken over to a tree, spent the day and the night in the tree, and they watched their aunt drown while they're sitting up there. These are just tremendous stories of hands-on, and then we've got lessons learned from these stories in this supplement.
Yeah, and I want to disagree with Cardin in one particular. The thing about Katrina that is particularly worrisome to me as a planner is that Katrina really was the likelihood of an event like that happening in New Orleans was pretty well established. It wasn't a surprise. Mm-hmm. It was an event that we had advance warning for. We knew it was coming, and it evolved relatively slowly. Mm-hmm. I mean, and still with as regards pediatric care in particular, we were woefully unprepared to deal with what happened to those care environments down there. Now, I mean, heroic efforts and informal networks managed to improve things, but there was no, we talked about the numerator and the denominator a little bit, there was no massive increase in the number of kids trying to get into the system. All we had was a system that could no longer take care of kids that were already inpatients. They had to be sent somewhere else. The vast majority of other kids, if they didn't drown, they didn't have, they had diarrheal illnesses or whatnot, but we didn't see a huge influx of hospitalization or requirement for hospitalization. Compare that to what we expect with something like the flu, and you can see that our level of preparedness is pretty, is not as adequate as I think it should be.
We've been we talk on the adult level, and we've had broadcasts on this sort of the lessons learned, what went right, what went wrong, how where we weren't prepared, what needed to be done. I don't know if this is a fair question, but can you compare sort of, relatively speaking, the pediatric healthcare system to the adult system in terms of how well did we do in Katrina? Were there more problems? Were we less prepared than the adult system? Is it apples and oranges?
Well, I'm not really that familiar with the adult issues, so I'm not at liberty to comment on that. But I will say that I think the pediatric response was surprisingly effective, even though it was inadequately planned for. And part of that is because of the scale of the disaster, which relatively speaking was from a high-end pediatric care point of view, relatively small.
Right.
So informal networks could manage that. So you had a lot of informal networks, a lot of communities reaching out, hospitals reaching out, going to get babies or going to get children and bring them and take care of them. But I don't think we did that as well as we could have if we'd planned better. It's certainly, there was a lot of mismatch of resources. In Birmingham, I know we had crews waiting at airports for babies to come on the National Disaster Medical System transport at the same time that in Texas they were swamped with patients. So I don't think there was a nice even distribution of patients. So we could have done a better job with that.
Yeah, we could have done better. I think we did fantastic. And I think part of it is because of this network. And we'd been talking before, Martha and Tony and others have been talking before with Tulane and Nashville about what to do in a disaster, and hurricane was one of those. And so when the hurricane hit, then UAB was able to respond rapidly and get a helicopter down there as soon as a call came from Ochsner to get some babies out. So I think the babies led the evacuation from disaster. The children led the evacuation.
Because of this
informal
or formal? Because
Well, I'd like to take credit for that, but I don't think I can. I think it's more just informal relationships. People know. We have been working on more, trying to get more planning in place. But most plans, remember, are built around local responses, generating state responses, generating federal responses. But in pediatrics, a lot of the care is a state may not have that many resources. In Alabama, for example, there are a limited number of resources that can take care of very sick children. And so our natural tendency is to go across state boundaries to Atlanta, to Nashville. And when you start to do that, that goes against the kind of pre-established working relationships that most disaster plans are built around. I want to talk about one more population so I don't forget about it, and that is the chronically ill kids too. We tend to focus on the acutely ill population, but you have a large number of kids on chemotherapy protocols, dialysis. They need to access home vent kids. When the power goes out, they need power. And while I think we did a credible job, I don't want to undermine that or minimize that. Again, we didn't see a big upsurge in kids who needed services. There wasn't dramatic pressure on the care network. In a larger event that produced a lot of injuries of a significant nature, I think that these kind of informal relationships would be strained mightily.
And I have two comments that actually, in listening to you, you mentioned the National Disaster Medical System, and I know the Pediatric supplement mentions this, but when in terms of the adult system, there's only 2 teams of pediatric specific capabilities for NDMS, and I think that's an issue. And I think there's a third one being developed in California. There's one in Boston, there's one in Atlanta, there's one in California. So again, that kind of gives you an idea of where we...
And that's it at the national level,
Yes.
3 teams?
2, well, 2 and I get 2.5.
Designed for pediatrics.
Designed specifically for
Boston,
pediatrics. Atlanta, and then there's one in California.
Loma Linda's developing.
What about the middle part?
Well, I think
There's some need out there.
yeah,
I think
absolutely, and I think that's certainly something. And then you mentioned the chronically ill kids, and I think mentioning the kids on chemo and the dialysis, but also those children with special health care needs that are just being taken care of at home. The kids that are on medicines, the kids that just have behavioral issues, or this may be a bad example, but a kid in a shelter without their Ritalin, and you've got, what kind of issues?
That's not a small issue. It's not your kid, and you're not in the shelter with them. But if you're in your shelter with a child, a hyperactive kid, your family unit's under a tremendous amount of stress.
Absolutely.
That's a significant issue.
And that's part of the preparation. If you have a pediatrician or a child advocate that's on this planning group, then you think of a shelter, then you would think that there's going to be a crying newborn or a 2-year-old or an ADHD child. It's going to be disrupting all the volunteers, all of the evacuees, and making havoc of things. And so you have to plan for it. It doesn't take too far for a child advocate to think of that. And so I think that's one of the reasons that we need to have an advocate on the planning. So I mentioned before, the lack of diapers, the lack of formula was a big issue on the Gulf Coast for the children who did not evacuate, who were not there, and there was a problem in the shelters as well. Then the durable equipment, the MDIs with the spacers, got to be.
Dosing size is really important in kids. You know, simple things like taking large bulk doses and breaking them down to doses appropriate for kids. You know, that's it's a packaging issue, but it's important when you're dealing with kids.
I think we could have an entire satellite about children with special needs
Sure.
and those
we could.
issues in medical shelters, because I've heard stories of people saying, you know, what happens when we have a child that has a special need, is on a vent, but we're sending them to the medical needs shelter, but yet what do we do with their family? I mean, that's a real issue that I think needs to, again, I think we're raising questions, but just saying these are things to consider.
Is it because of the relatives? You know, I always end up asking the same question. Why? It makes sense. It's logical. Why didn't we do this? Why did it happen? Is it? And I guess there's two things I'm thinking about. One, is it because proportionately, like you were saying, Tony, we've got less of them, and so that's why we haven't paid as much attention? But I guess the other piece that I'm thinking, when you talk about not having enough diapers or formula, you know, is there this general feeling that, well, that's the parents' responsibility, and it's not part of a care delivery system? I mean, why is what if you have to speculate, why did this happen, and why is this happening?
It's a pediatric mantra. This is the thing that we keep shouting about. Children are not little adults. And when you're sitting around planning, you're in Washington, or you're having a meeting like this without pediatricians, and you don't think of the special needs of children. You don't think that they're going to be there. You say, oh yeah, we're taking care of everybody, and you include everybody in that plan.
Well, just as an
So it's
example,
omission.
you know, if you're in New Orleans and people need something to drink, your natural response is, well, let's give them water. I mean, that's what they need. But if you, if what people have to feed their infants is just water, they don't have formula, then you're going to get a lot of kids with electrolyte abnormalities based on the fact that, you know, kids can't just drink large amounts of plain water like adults can. So something that simple naturally would come to mind of people planning for kids. It doesn't necessarily come to mind if you're planning a big bulk operation. There's some other issues I think with kids that are particularly interesting to me. Is, you know, we also talk about volunteers and kids, and we have kind of a double-edged sword with kids and volunteers. On the one hand, you know, people rush in to take care of kids, and I think there's several examples in Oklahoma City where people came in, tried to help out with kids, and actually got hurt themselves, and we worry about that with our providers. The other issue is you have unique vulnerability kids that you have to screen and take care of, making sure that you don't have predators and child abusers, pedophiles coming into the workforce to actually take advantage of the situation and volunteer to take care of kids when they shouldn't be involved in the care. And that's a tricky situation for us as care providers. We want to take advantage of people's willingness to help. We want to make sure that they don't get injured and make sure they're not in a situation to be predators to kids as well.
Yeah, now that's key to one of the points that I want to make, that the private sector responded tremendously in this response and got children out of harm's way and got them out of the disaster area. The NACRI, which is the National Association of Children's Hospitals and Related Institutions, those administrators knew each other and been talking to each other, so that when the disaster hit, then you call the feds for help and say, look, I need a C-130. Well, it's not forthcoming. So you get your own airplane, you get your own jet, your own helicopter, and you get them out of harm's way. Now you could call these, you know, I was kind of trying to think of an analogy, and it's not like herding cats because it's a little different. It's more like ants. They're just going everywhere in every different direction. But it works. And it worked this time to get the children out. And in preparing for the next disaster, the predicted part of it's going to be unpredictable. Hopefully, after we keep learning, more and more will be predictable. Some of it will be unpredictable. These ants will be out there, and they'll be providing services that are needed and necessary. So I think it behooves us as planners not to omit all these people who are going to show up, well-intentioned, most of them well-intentioned, most of them helpful, and being somehow able to include them in the process.
Well, I have a couple actually it was the last broadcast, we had Jim Craig here from Mississippi, and he was talking about one of the things that happened for them was this immediate need to leverage the private sector. And the question that I asked him was, you know, what did you do when all the volunteers were there? Good intentions, Was it a problem? Because we've heard these sort of stories that people with the right intentions but not the right credentials, etc. In Katrina, in the other disasters, has that been a problem? I mean, or has it been one of these things where people show up, they want to help, and we're able to kind of diffuse them out appropriately? I mean, have we seen problems there? Bringing in the private sector.
Or the private sector coming in by themselves.
Yeah, I mean, it sounds like it's something that we don't have in our plan per se, but has it been problematic previously?
How big of a problem has that been? And I have not heard of a lot of problems with it. I know that there were people coming into the Houston Astrodome saying they were docs when they were not. And so they start providing care, and then after a while it becomes obviously they're not a licensed MD. But then that requires some sort of supervision to be sure that they're all right. The problem gets to be a lot of times security, of course. Mm-hmm. So you not only have the do-gooders, but you have some people who are hungry, who have their own personal needs and are taking advantage of the system. So we have to watch out for those. But I've not read a whole lot of press coverage about people volunteering to come in and then creating havoc and creating problems.
I know that ADPH does have a program set up to train volunteers, and how that, I can't really speak to that too much, but I know that is in place, and I think runs fairly well. I'm looking at Michelle, so.
Yeah, one of the problems would be that as those volunteers come in, then they do want a place to sleep, and so if you use the ants have to build their own nest. Right. They have to create that, because if you start putting them up in the hotels and motels, that's where your evacuees are, and you don't want to have your rescuers who are relatively healthy trying to deal with the evacuees who are emotionally distraught, physically distraught, and medically challenged.
But I mean, when you talk about the private sector, volunteers is one component of that. But some simple examples of how the private sector, certainly when you talk about hospitals and care venues, in Katrina, you had a significant response, I would say. But there's no reason why we can't plan better. I mean, during Katrina, when it became clear that kids were going to have to leave New Orleans, we had a special notice from the Medicaid, the federal government, that Medicaid would be functional across state lines, that they would somehow make providers whole. Well, that's something that we can deal with ahead of time. The fact that kids are in a fragmented federal insurance program where each state has its own little rules and its own Medicaid agency, as opposed to adults who have a federalized Medicare system. I mean, we can pre-plan to eliminate those kind of barriers before disasters happen, and make sure people understand how those things are going to work, so we're not scrambling to try to do that in the midst of a disaster. Those are simple kind of things that I think we can take care of ahead of time.
I don't know that they're all that simple. I think it's going to require, but at least you can conceptualize them and identify them. And having a conference with the purchasers and payors and providers, I think, in the room and the patients is extremely important to try to work through those issues.
We keep hearing about all hazards approach that we're supposed to, and I mean, we talk about it, but as we're talking, and I keep thinking, I thought this on the adult level too. Pandemic flu. We talk about something like a hurricane, that we see it coming, sure. And it smacks us, and we have casualties that way. Can we think about something like pandemic flu the same way, or is it so different in its nature that our plans and preparation need to be very different than from a hurricane?
I think it's different. It's a national event rather than a localized event. That pandemic flu, as it's conceptualized, is radically different because it involves all national assets, and it will affect every environment people are in. I mean, it'll have a tremendous impact on school, on social functioning, on work. Have a tremendously profound impact on mortality rates if the predictions are anywhere near close to being true, and the demand will be incredible on care systems. So I think that's a whole different.
I'll take the opposite. Okay.
Yeah, sure.
I think some of the lessons we have learned, although there will be different problems with pandemic flu, the lessons we've learned from Katrina are applicable. And one is that you have to have this child advocate on your team to manage, to prepare, to manage, and to take care afterwards. There was a concept that developed during Katrina in the shelters and in the domes. We used the Pete Maravich Dome in Baton Rouge and the Astrodome in Houston and the Dome in Dallas. Parallel systems developed for children. So you'd have all the people in a shelter, and then you'd set up a healthcare system for minor illnesses, diarrheas, vomiting, and you'd put that in a shelter. But then automatically, almost without thinking, the children shifted over to be a parallel system. And so instead of the children going through the system, they were parallel. And that may be the same thing in flu. I would think that flu would develop the parallel system. The public versus private we talked about, that would be there, that would be working. Reimbursement, I think some of those issues would be the same. Knowing people beforehand so you can respond would be the same.
Right.
And then we get into the thing that hit us in Katrina, which was poverty. Those who did not have a good insurance system in a medical home, the medical home being a place where a child can go and get compassionate, continuous, comprehensive care, like a pediatrician or family physician's office. Those kids without a medical home and without insurance did poorer. So poverty is going to be an issue, I think, in flu as well.
And I think also, Carden mentioned the knowing who you need to talk to, and I think sort of gets off your question a little bit, but maybe the difference between a hurricane versus the flu is that the flu is bringing together partners outside of the hurricane that wouldn't naturally. It's bringing together schools and EMA, and it's not that they're not already hopefully working together, but it's pulling in the health department and the Department of Education. It's kind of making those venues and those connections even stronger. So if anything, I would kind of take the approach that we're prepared for the hurricane, but the preparedness for flu is just going to build that infrastructure to respond to anything even more. Does that make sense?
Yeah, no, it does.
Yeah.
I guess my other question that we talk about, prepare, have a child advocate on your team. Who should that child advocate be? What should there just be one? What else should be on in order to meet the needs of children, do you need a sub-team or is it just a representative on the larger planning team?
You need at least a representative. I think the Academy of Pediatrics, the other child advocacy organizations, Children's Health Fund, the Children's Defense Fund, will be advocating for children as well. But so I think there'll be some teams. If you can get one, that's the step in the right direction. As you start getting into different issues, then that child advocate may call on others to support. Because as you start talking about radiation, you start talking about chemical, you start talking about infectious disease, so they're going to have to pull in other people, I think.
Well,
it gets extremely broad pretty quick.
I mean, can you talk about examples of whether it's a children's system in Alabama, of the team? What should the ideal team look like?
The team, you mean as part of the regional planning effort? So
Yes.
I think the fundamental question you have to ask is the regional structure, the current structure that we have to manage disasters, is adding a liaison from the pediatric community sufficient? And we may disagree on this. I think that for certain disasters that's fine. I think that that it certainly can't hurt. But I believe there's a class of disasters, and Katrina was one of them, where regionalization of pediatric services needs to occur, i.e. kids need to leave one state and go to pediatric providers in other states. And in that kind of a disaster where that's appropriate, I think what we need is more than just a liaison on a committee. We need a structure that understands that and allows that to happen. And that requires a little bit of a change in our mindset about how disaster response should occur. Because we have a very hierarchical structure for disaster response right now. Local, state, federal. And there's certainly lots of merits to that. just in certain kinds of disasters, I think it's important to have more a system that it's easier to cross state lines earlier in the process than the system we have now, as I understand it and as I've experienced it.
Can I?
Yeah, go ahead.
I was going to pull this as kind of
Sure.
going back down to a slightly different level, but even thinking about the planning component from the public health perspective of ensuring that you're not only are you just thinking about kids and saying, okay, well we're going to consider what we're going to do, but when we're designing drills and exercises, that kids are incorporated into that somehow. That we are forced to plan for children in an event of some disaster, be it however that might look in your health department. And I think from the health department perspective, also pulling in those folks who deal with children on a daily basis, be them in clinical settings or otherwise, the Title V agencies, the agencies that deal with children with special health care needs, children's rehabilitative services. I'm speaking with Alabama terms right now, but Bureau of Family Services, making sure that those entities within the health department are wedded with the emergency preparedness, so that there is that advocate, if you will, but it's not just a person, it becomes kind of a mindset that we need to not just remember them, but we don't even have to think about them anymore, that's just a part of what we do. That would be...
How are we doing on that? I mean, because particularly when you talk about the people that are involved with children from a non-healthcare standpoint, I mean, short of parents, we're talking about the schools. And we're talking for a large proportion of them who spend the majority of their day, that's where they are. And yet now you talk about state health departments, and now you're talking about education. Are we integrating them? Are the folks at the state health department able to speak with the people in the education programs or the schools and with regard to preparedness? Is it coming together? Because you can see how it potentially wouldn't.
Mm-hmm. Do you want me to segue right now into the conference? Or this is a perfect segue. And the reason that I was talking about the different entities that the health department speaks to is because of the conference that we're going to be Alabama Department of Public Health, Alabama Department of Education, the South Central Center, Children's Hospitals, and a number of other groups are convening a 3-day conference in Birmingham, June 27th, 28th, and 29th. And we're focusing on mental health issues related to children as well as planning issues. And again, I think that kind of answers your question about who's sitting on this advisory panel for the conference, and who have we gotten input in terms of who's going to be speaking and whatnot. So if I can address that issue on that perspective, but as far as the nuts and bolts, I don't think I'm necessarily the best person to answer that one.
I was thinking about what Tony was saying about this idea that we need to be able to go beyond the state lines from a health care standpoint. But then, as we were talking about sort of where the kids are, how do you integrate that with the education part, or just I don't mean education, but the school, where these kids are, once the disaster strikes, taking a kid who's in Alabama, moving them over to Mississippi for care, et
I mean,
cetera.
the gap between the healthcare system for kids and the public health system for kids and the school system that, where kids are at, I mean, each one of those intersections is wider than it should be, and certainly between healthcare and schools, it's a pretty big gulf at times. I don't have an easy answer to that. What concerns me about the schools is we're asking them once again to take on a new mandate, when they're supposed to be educating kids with probably no new funding, and I mean, it's so I worry about just asking them to take on another task without thinking through how we want them to interface with the rest of the system. But a lot of people are interested in working on that, and I think this conference will be a nice opportunity to explore some of those important issues.
Josh, planning comes from the top down and starts at national, regional, state, county. It also starts from the bottom up. So we have to think about what we would do now, each of us, if we were to have a disaster event. So for all the audience that's out there now, have them think of what they would do. Are they planned, and are they planned for their family right now and their own children? With having disasters and hurricanes hit Florida for a long time, the Florida chapter of the American Academy of Pediatrics developed a nice family disaster readiness kit. And the public can go to that easily, www.aap, that stands for American Academy of Pediatrics.org/terrorism. And then under there's family preparedness, and they click on that and they can find the kit. And it's not only the kit, there's a lot of other helpful materials that will help you decide what you do for yourself and your family in a disaster situation. Also, ready.gov. The federal government has done www.ready.gov, and on there is activities for children, similar to, I think, the Duck and Cover video, but now it's 2006, trying to involve kids into some preparation, meaningful or not, but at least they're getting involved. So those are two websites you can go to and think about. Coming out of 9/11, we know what every parent knows. In a disaster, what you're concerned about is your family. And you're told not to go down South New York City because it's a disaster, but your child is down there. And there's no way that we're going to stop you from going down there. Working through that is going to be a tremendous issue, I think, over the next few years as we prepare for disaster.
We way underestimate the impact of uncertainty on the actions of parents as they try to reconnect to their kids, and I think that was shown in Washington D.C. The Children's Hospital there had a tremendous problem with staff trying to get in touch with their kids during 9/11, and cell circuits are down. People are used to these technological ways of getting in touch with their kids, and that most of them don't work in disaster scenarios, and it causes a lot of stress, but also a lot of deterioration in the functions of workplaces at times too. So.
Yeah, I mean, I guess one of the things that I'm very concerned about, we see it in even in more minor situations, at least locally. Tornado warning, and you hear all the time, at least locally, or even a severe thunderstorm. Don't go get your kids if wherever they are they're safe. And what's the first thing that many parents do? That is the signal to them to go get their kids. How do we go, we were laughing to some degree about Duck and Cover, how do we prepare kids and families to take this stuff seriously, but at the same time not overly create anxiety, or the other extreme, which is create a sense of sort of complacency and, if you will, denial? What do we do? How do we do it?
I want to go back. The first question that you asked on the intro was, are we ready to help children? And I think you actually hit this nail on the head. Who is the we?
Yeah.
I mean, I think as parents, as providers, whatever your role is, that we takes on different meanings. So I guess from that perspective, what we are you talking about?
Well, I don't know.
Who is we in your question?
Yeah, well, it's easy for us to be one or the other.
Yeah.
As public health providers, we can put that hat on, but then as we've all said, as soon as the thunderstorm warning comes up, and if we flip back to parent hat, we're likely to commit the same problems that we're trying to get. So I don't know. We need an integrated we. Will this network help? Or the conference and the network? I mean, it's bringing educators together, but do we talk to public health providers in these sort of dual roles? You as a parent and you as a care provider, or do we tend to separate it?
We tend to separate it from the pediatric standpoint, but the Academy of Pediatrics does have a nice statement that came out about disaster preparedness, and it starts out by saying, prepare your family, prepare your office, prepare your community, and then get involved, into your county and state level. So I think if we can get healthcare providers thinking of their own offices, then they can grow from that to communities. So hopefully we can do that. The missing child issue is again mentioned in this, has an article in this supplement. And as we know, there were 5,000 children who were separated from their families during during Katrina, and the National Center for Missing and Exploited Children over 6 months got all of those children back together. So it was a tremendous effort. But parents would be waiting at the dome, a bus would come along, and they would say, we don't have room for everybody, and then just throw their child down to get them out of the disaster area. And then leave New Orleans, go to Houston, go to somewhere else, and transfer two or three times. And the child was safe, and then trying to reunite those got to be a tremendous effort. So we are learning a little bit about how to
6
reunite.
months is a long time,
6
though.
months is a long time to go without a child. Most of them were reunited within 3 weeks, but 3 weeks is a long time to go. And it's just tremendous.
You know, in that particular case, we know that the media played a huge
True.
part. I mean, it didn't even matter what the cable network was. Everybody was having people who had been separated come on and post phone numbers and post. We talk about that again in the adult system, that from a risk communication standpoint, media can be a critical partner. Do we need to think about it any differently when we're talking about kids? Do we need the media to interact differently with the kids or with kid issues than adult issues? Is it something that we even think about?
The pediatric issues, I think, in communication, rapid communication, are immediately are important. So to get the message out correctly, and you can pre-think a lot of these messages and get them out. I think that we do have to be sure they're child sensitive. We do know the media plays a tremendous part in making the child more and more anxious post-event, and so we have to watch that. But to get the right message out at the right time in the right way, I think we target that toward the adults and the caretakers.
Do we need more Bert the Turtle type?
Well, I mean, I think, certainly to the extent that you want kids to do something, the content has to reflect their intellectual capabilities, which varies by age. But I would just echo what Garden said. I mean, certainly the media has tremendous power. My only hope would be that during these kind of times, we could focus on information that actually is valuable and has is legitimate information. Oftentimes, the signal-to-noise ratio gets a little distorted, and it's hard for parents who are already struggling to really grasp onto information and know that it's information they have to act on or should act on. There's just so much noise out there. You bring up the cost of the false positives with storm warnings and whatnot, and I think we have to be sensitive to that with kids. There's a long-term cost, as those of us who spent years watching Bert the Turtle and ducking and covering, know. I mean, it's again part of the reason we find it so ironic looking back on it is because we experienced that.
Right. We're not done, but we are getting ready to take your phone calls and to take your email messages. So start calling, start emailing us. I want to, as we're nearing the end, we always do a good job of we bring up lots of issues and we bring up lots of nuggets of information and what we should do and steps. And I know it's impossible, but can we sort of package it and say, okay, where should we go? What should we do now? What's the first steps in moving us towards this level of preparedness that may take a long time to reach, but within the hour of this broadcast, what should people know as they're leaving, as they're turning this thing off, the first important steps that need to take place, or the most important from all of your all's perspective? Should I pick on you first?
That's fine. Yes. Well, I'll go back and reiterate just kind of the broad point that children are important, which we know that. Children, anytime you talk about kids or babies or anything like that, people automatically soften. But I think remembering their specific needs in the context of a disaster, whether you're in a hospital setting, whether you're in a public health department, whether you're a private provider, whether you're a school administrator, whoever you are, just remembering that there's some very specific issues that children, about kids, that need to be considered. So that's a very broad, I could go into more specifics, like I said, the drills and exercises, in the communication with some of these entities that we've talked about. So,
has the American Academy, has anyone put out a checklist, if you will, for planners?
We do have a lot of information on that website, aap.org/terrorism, about for planners. It's checklist for families, but it's not that much of a checklist the planners yet.
And I think that's an issue in and of itself, that all these we've taught. There's a lot of resources related to children and providers, or children directed specifically at children. How do we help them deal with the psychosocial issues after a disaster? But in terms of how do we integrate them, that's not something I think we've seen illustrated. We haven't quite gotten to that level yet. So from a planning perspective, so I didn't mean to jump in, but
and the 2 points that I want to make are the ones I started with. So have a tabletop exercise in your family, in your office, in your community. Include children in that tabletop exercise. Make sure they're included. And then also include the private sector. If a disaster occurs in your home, the neighbors are going to be coming, and they're going to be trying to help. In your office, there are going to be people coming from next door. In your community, the people are going to be coming in. So be sure that you include these well-intentioned people in your response.
I would just say kids aren't adults. In your current framework of how you're planning for disasters, include somebody who understands kids and kids' issues. Kids are embedded in families. So if you're not thinking about family issues, your disaster plan doesn't think about family integrity, family reuniting. That needs to be thought about in more detail. And I would encourage at a national level consideration of a more sophisticated regional approach to managing kids when appropriate. And I think in Katrina it was appropriate. It did happen, but it could have happened better.
Okay. Michelle, do we have any phone calls or emails at this point?
No.
That's okay, because I've got a ton of questions. John knows. We have danced around the psychosocial issues. And that's okay. I mean, as a psychologist and the moderator, I'm always trying to keep my interests somewhat at bay. But the psychosocial issues are huge, and we do talk about, dealing with helping kids cope after the fact. For me, the more interesting question is this: you talked about involve the kids in a tabletop exercise. How do we integrate children on the preparedness and the planning side appropriately, so that we don't create too much fear, or that we create enough anxiety that gets them moving? How do we know how to do that so that they can become a part of the preparedness plan? Or do we not? Or do we just sort of deal with it afterwards?
Well, I know what we do with in the home, because in the fires, house fires are the leading cause of death in children. So we encourage families who have small children to have a fire drill. And you hit the smoke detector in the middle of the night and see if the kids will roll out of bed, crawl on the floor, touch the doorknob, crawl out, have a rendezvous place so they can reunite outside the house. So we do include children in that. In the local area, Children's Hospital and other states, I'm sure, have had decontamination drills. And so the children dress up in these little costumes and come in, and we go through decontamination. I don't think, as long as they know this is acting and this is a play, I don't think there's a whole lot of anxiety built up on those one-time events that they're having. But that is it is a concern that you don't want to get so compulsive about planning that you have them afraid of every lightning bolt that goes out that they have to go duck and cover.
What about post-disaster? I mean, one of the things we saw with Katrina, both at the adult level and the kid level, was you had the initial impact, and then you can make a laundry list of all the subsequent traumas that, from family separation to physical separation to injuries. And one of the concerns was not the immediate psychological impact, but sort of the down the line once the kids were getting into their new schools, etc. How do we deal with that? How do we deal from the mental health standpoint, the longer term effects? And is that something that obviously we'd like to take it into planning consideration, but how do we bring that in there? The mental health needs down the road following a disaster.
Again, that's a satellite in and of itself, I think, and I think that is a question that I know agencies are really trying to address. But from
working with the schools the National PTA, the National School Health Association, and our School Health Committee tried to have a policy of move the child once, because if they leave their home, they go to another area and they're in a school for a week, and another school for a week, another school for a week. This is going to propagate the issues. So you try to move them as little as possible, and you put them on a higher priority list. So that's one of the policies that you can try to propagate and to make a higher value. And so we do have different plans for dealing with children's anxiety depending on their age group. So the adolescents are getting into concrete thinking, and they can start talking about it a little bit more. The school-age child doesn't understand it quite so much, but answering their questions is a valuable sort of thing. And whereas the preschool child, then drawing, acting out may be a thing to do. We do know that you don't want to ask them to relive their experiences over and over and over. We found that out.
Yeah. Well, I'll just go back to the fact that kids are embedded in a family context, at least ideally, or some kind of social network. And our disaster plans ought to the extent that's possible, respect that family unit and try to at least maintain it together as much as possible. And if it needs to be violated in some way, bring it back together as soon as possible. And that I think, again, is a fundamental principle in pediatric kind of thought processes about disasters. And it's not always easy to do, but knowing that you're going to have to reunite the families and how important that is, I think it helps you plan for it.
But educating families, parents, whatever adult caregiver it would be, educating them to watch for those signs and symptoms that you mentioned about kind of the warning flags related to.
Yeah, I talked to the Mississippi chapter of the American Academy of Pediatric Study, and so they've taken a form that was fairly complex to give to parents and have simplified it. So there's just some basic questions, depression, anxiety, nightmares, are you having problems? And then they've worked and actually hired a mental health worker to go into schools. And so they can help with those schools and help educate the teachers. They give a form to the teacher so they can make observations. They give a form to the parent so that the parent can make notes and bring those in, and so they can identify the high-risk children and try to get them into therapy. The children who seem to need the therapy the most, parents are not signing permit slips. And so now we have another problem of trying to communicate from down up.
We've got I think we still do. We have someone waiting on the line?
We do.
Who do we have and where?
We have a caller from Texas on the line, Josh.
Okay. Hello, Texas. What's your question, please?
Hi, I have a general question for anyone out there. We spoke earlier of the parents being separated from the children during the natural disaster Hurricane Katrina. How would you propose to minimize that? I know it must be a huge effect on each family being separated from their children. I know as a mother I would hate to be separated from my children. How would you propose to minimize that in future disasters?
Well, I can only speak personally from my responsibilities as a hospital administrator. But for example, when we initially planned to decontaminate kids, we planned to decontaminate kids, not families. And that meant of necessity that we were going to separate kids from their families. So it took us a while to come to the realization that was kind of not a smart thing to do, that nobody who had been exposed to a toxic agent was going to want to leave their toddler in a line to get decontaminated and go down the street to our partner adult hospital and get decontaminated. But it just requires that kind of thought process. And again, it's not always going to be possible to do that, but it's surprising, how you get into administrative kind of frame of reference and separating people is efficient sometimes. And so I don't have an easy answer to that, but I think on the margin we can do a better job just by taking a broader view of things like decontamination and thinking about, doing the whole family instead of just the kids.
Kansas City Children's did a great job with that, in that they sent down a C-130 to evacuate the children out of the Children's Hospital in New Orleans. They sent another 130 for the parents. And so they were able to reunite rapidly, whereas on the helicopters that didn't work. So how do you prevent this in the future of being in a dome and you have limited buses, and the buses are coming by and picking up a limited number of people, and you as a parent want to get your child out of harm's way. I think the planners can think of a bracelet, just like you do in the hospital,
Right. Sure.
and with a number and or identification, and so that the contacts can be easier.
Yeah, I should mention in Katrina in particular. And again, I was in Birmingham during Katrina, so I don't. But at the actual point where families got separated for environmental reasons from the storm itself, there's obviously not much you can do there. But once they reach a care point, making sure that you have some kind of robust identification system is obviously very important, and that's something we've worked on locally, is to make sure that when a family unit comes into our care system, that we're prepared to tag the whole family unit and link them together, not just the child who's the index case that's coming in for care. And again, that's it's a mind shift, because during normal business operations, we don't really, we assume that identification is going to happen easily, but not in a disaster.
Right. The tornado that hit in Birmingham was, again, infrastructure's intact and we're closed. But during the night, we found that the emergency department hospital was working very, very well. It was very quiet. And then you think, this is not normal to have a quiet emergency department. So the parent, we had separated parents from children. So the parents either went to another hospital, or they couldn't get there, or worse than that, they were deceased. And so we were dealing with the children, and so the medical care went very, very well. We called in social workers. Social workers got their Polaroid cameras out, went around, and by morning had them all identified again. So in a small disaster, then I think you have techniques of reuniting that can work a little easier.
Josh, we have a question that's come over the email.
Okay.
This one is coming from the Preparedness and Response Nurse Coordinator from Oklahoma City County Health Department, and her question is, oral suspensions may not be available via the SNS, the Strategic National Stockpile. Please address the issue of emergency preparation of Cipro using adult dosages of the medication. The FDA has developed instructions for Doxy, but to date no similar information exists regarding Cipro.
Well, if you're asking for a recipe, I can't. I certainly can't provide that. But I do think it highlights the issue of oftentimes we think delivering bulk medicines to a site is going to be adequate, but when it comes to kids and small kids in particular, it's not adequate. We've got somebody who knows something, who knows enough, has to be able to organize that into dosages that are appropriate for kids. And obviously that's something I can't do, but we have pharmacists who've planned to do that in our organization. It would be nice if that was if Lisa Stockpile had, there's more details on how to do that, but I don't know if you have other from the academy.
No, I don't. Not a whole lot. The academy works with the Strategic National Stockpile Medicine for Children through a ped pharmacologist in Massachusetts, and so we're depending on that person. But they're not meeting often enough. I think the last time I talked to them, to be sure that children's supplies are adequate. We have a pediatrician from Bay St. Louis, Scott Needle, who was hit, and he's looked into it, and so he does recommend having some antibiotics. Obviously, they don't need refrigeration, that will stand the test of time for a few days, and have those in the stockpile. So that's not a very good answer to a very good question from Oklahoma, I think.
Anything else?
We have no more questions right now.
Let's do this. Again, we've sort of covered everything. You've given your summary points. I always leave these broadcasts, on the one hand, very encouraged, on the other hand, just the enormity of what we have to do. Scale of 1 to 10. How prepared are we at the, let's say, the regional level to handle a disaster with kids? From your perspective, are we closer on the 5, 6, 7? Or are we 0, 1, 2? I mean, there's always more that we can be done.
Absolutely.
But I guess I want to take out of this, relatively speaking, how well are we doing? How prepared are we?
I think it depends on what level
Okay.
look at. Again, I think this goes back to that we question. Who is the we that has that expectation? Because if you think about it from a family perspective, as parents, I'm not a parent, but as parents, I'm sure that you would do anything that absolutely possible that you needed to do. From an organizational perspective and a systems perspective, we're not there. And from what I've seen from my perspective, and I don't think that's not necessarily all bad. That's not a negative because someone has overlooked it. It's just not something that's come up to the forefront yet, and I think that's across the board. So I'm trying not to be point too many fingers, but I would say there are organizations such as AAP, and there's national committees that are working on policies, getting legislation passed related to children. SNS is part of that. I think that took place in 2001, 2002. So there's policies in place, but it's just getting that rubber to meet the road that I think there's the gap there.
Is that where the pediatric network comes in?
The pediatricians will perform a tremendous role, I think, in disseminating accurate information to a large number of people. So the role of the American Academy of Pediatrics is to get that information to the pediatrician. So we have designed a website with good information. Now, it'll have to be brought up to date on a day-by-day, maybe an hour-by-hour basis, so that the information can go to the pediatrician talk to their families, and then that is communication, that's reassurance. I think that's one of the ways it's all about. We're not ready for that. Okay. The other thing that the pediatricians will do will be to detect the sentinel case. So a child comes in with flu and you treat them as flu, but then 2 days later they die. And so that's got to start ringing a bell, and you've got to say, okay, I got to call. Who do I call? And so we've got to nail down those direct lines of communications. The laboratories in the hospitals have done a better job working with CDC. And so as they come up with funny lab tests, then they're part of a network and can get right into CDC. So for that part, we're ready. So we're spotty, I think, is what we're saying.
Well, I would start with Carden, start off the broadcast by saying that he thought kids were our most important resource, and I would agree with that wholeheartedly. And I think that, sure, at a gut level and at an individual level, we put kids, we value kids. But at an organizational level, at state, regional, local, and national levels, I don't think kids, they don't. When everybody goes to the trough to get resources, kids are the ones that are the runts of the litter. They don't get it. They don't vote, and they're not a priority in our planning. And I think that's regrettable. And I think we could do a much better job. And parenthetically, I think that if we did a better job planning for kids, we'd also do a better job planning for adults as well, because a lot of our adult population is vulnerable like kids, and a lot of them are not in the context of a disaster. Like kids, they're not capable of independent decision making. I mean, for various reasons, just the trauma of the event. And so if we thought about kids more and planned better for them, I think we'd do a better job for all of us.
That's an important point.
I think the advocate, we talk about having an advocate for children, but just as a parent, as an aunt, an uncle, as someone who is interested in children, just being an advocate in whatever that means. So.
Josh?
Yes.
We do have another caller on the line and a couple of email questions that come in as well. So we'll go to Texas first with the phone call.
Texas, hello. What's your question, please?
Yes, this is my question. I know that we are concerned about the emotional well-being of our children as it relates to the subject today. But my question is, do you believe that a greater level of support for our national preparedness could come from our foundation up by instituting more classes to our children? I mean, we teach sex education and other subject matters. If we would start educating our children, our community. Today, I'm here watching you, and there are only two of us, and we were discussing where is everybody. And of course, we have some answers to that, but just putting that more out there in an educational presentation, do you not think that that would help us as a whole?
Go ahead.
The educating the children is somewhat important, but I think educating the adults and having a system ready to go is more important. The schools now, instead of doing fire drills, are doing lockdowns.
Right.
And so, they're already preparing for a minor terrorist event. Trying to do more than that to the children, I think, would make undue anxiety. So I think it takes the planners around the school boards, the PTAs, to try to plan for disasters and work through it. So that's where I'm coming from.
I'd venture to say, not in all schools, but in some of our schools, that our kids are better prepared from a knowledge standpoint, education standpoint, than we are. They are being taught about lockdowns. They're reminding us about fire plans and safety plans, etc. So I do think it's nice to have education and to educate the kids and to keep that going. But I do think one of the challenges is, how do you get that to translate upstream or to the parents?
It's an indictment of us as adults. I mean, I just have a personal experience. Last week I was going to take my kid to a soccer game, and we were going, it was a 5-hour drive, so I went to school a little early to get him, and they had a fire drill going on at the school, and they blocked my car in, and I was extremely annoyed by that. And then it dawned on me, that I was being kind of selfish, that, maybe this was like a reasonable thing for them to do, but for the first 5 minutes I was supremely irritated. And I think we don't really, as adults, we don't want to face the fact that, that we have some work to do here. And it's really, it's not just the school's responsibility. I applaud efforts to educate parents. I'm not sure generating more anxiety in our kids before we reach the parents is the answer. But I do applaud efforts to reach parents. I'm just not sure how to do that. I mean, that's beyond the scope of my how to have an impact on the mindset of American culture is a challenge.
Well, yeah.
The news is doing a good job of trying to alert us to the problem of pandemic flu. So that's on a lot of newscasts. And I think they're doing a pretty good job of not making it too anxious, but trying to make us aware. Now, they sell their news by making us more anxious, but they're trying not to overdo that, I think. So then this pandemic flu preparation then hopefully will transform into disaster preparation and bring it up on the public awareness, and that's what it's about, I think. Not so much the children's awareness, but the public's awareness.
Email?
Yep, we got a couple of email questions. This one's coming from Volunteer Mobile, which is a volunteer organization here in Alabama, and their question is, where is the Safe and Sound Conference in Birmingham?
The Safe and Sound Conference is at the Sheridan, the Birmingham Civic Center, and to find out for registration, we've actually had a fantastic response. So if you want to send us an email, see about available spots, please feel free to do that. But you can visit our website, as I think it came up on the beginning of the broadcast, at southcentralpartnership.org/preparedness, and there's a link on the right-hand side of the page for the children's conference.
We've got all the details up on the screen right now.
There you go. You already have it.
All right.
Okay.
This last email.
Yep. This next email comes from the Community Relations Coordinator in Waco, McLennan County Public Health District. And her question is, where can I get copies or order the Emergency Preparedness Children with Special Needs packet?
That one.
This one. All right. Yeah. The American Academy of Pediatrics, and it's called a emergency information form. And so let me see if I can find anything.
I think it's on the page that you referenced. I think it's fairly well marked. I was there on
www.aap.org terrorism.
Right. I was there the other day, so I think it's
right there. Mm-hmm. All right. So it's a good thing. Spend some time on that page, that /terrorism page for AAP.
All right. Well, we're done. I want to thank everybody. I like the way we ended this. I always get a little concerned. We bring up all these big issues, but you all did a wonderful job of sort of pulling this home. I appreciate your time. Lots of good information. This was an important, obviously it's an important discussion, and the thing that I think is the most important, as our speakers highlighted at the end, spotty is a good word. We are doing a decent job. There's a lot more that can be done. But I think the most important is that we have to make children an emphasis, not just to think about them, but to bring them to the forefront. And we can all be advocates, parents or not. Children are our future, and being an advocate for a child in this situation is what's going to bring this home, and what ultimately is going to make the change. That concludes today's broadcast. But yes.
We do have another question that's just come in over the email.
Bring it
happens
up.
Every time.
Sure.
Okay. I'm from the University of Wisconsin Pediatric Pulmonary Center. One of the presenters mentioned don't ask children to relive their experiences. We learned that. Could you discuss this? Also, a checklist was mentioned for parents and caregivers to identify children who are having trouble coping with trauma. Could that handout be added to the conference information?
Those are yours, I believe.
Yeah.
Oh, yeah.
Yeah, we can tag team it. Go ahead.
Yeah, the part that I do know is that we did try to talk to children. We said we'd ventilate. Tell me about your problem, and tell me what you went through. And we found that we were generating more anxiety and more depression in those children. And so I don't have a reference for those studies. I don't know if we can get it on the website or not, but that's pretty well documented.
What we know is that pushing children to talk, and we know this is the same with adults too, is not necessarily beneficial, and in fact in many cases it's not beneficial. And that really what we need to do with children when you're talking about a post-traumatic situation is talk to them, allow them to talk, and recognize that they may be playing out their fears and concerns over a longer period of time and not just verbally and directly telling you their problems. Being there for a child to talk about everything and anything is probably the best thing that you can do to get at whatever is bothering the child versus this sort of directed, talk to me about your problems. Kids process information differently depending on the age and over a different period of time. And I know that we've had the same experience.
Instead of beating them over the head with your own agenda.
Yes, because a lot of times, much like adults, they will shut down.
Right.
And then the second question was, can the handouts...
The pediatric symptom checklist.
Yes.
And that's a standardized checklist that's available somewhere on the web. But it's the one that the Mississippi chapter decided that it was a little more complex than just screening large numbers of children who have been moved. And so they've developed their own simple screening tool. And so if we can get the the email of that person, and I can get them in touch with the Mississippi chapter of the AAP, or I might be able to look it up, but no, I think that would be the best thing to do is to try to get them in touch.
I think there's also some websites, and I don't remember that give very specific, detailed information about the age-appropriate symptoms as well.
The American Psychological Association, www.apa.org, has information. American Psychiatric Association. Both of those have specific information on how to help recognize signs of psychosocial distress in children following a traumatic experience, and that can be it's a very valuable resource.
I'll let you go ahead and conclude the program again. That's all we've got right now.
All I wanted to do, we need to conclude, but I want to tell you about a number of upcoming events. First, some broadcasts that we're going to be having. Let's see, on August 10th, August 3rd, guidelines and standards for weapons of mass destruction response. And then on August 10th, using GIS in disaster planning and response. And then upcoming conferences on June 9th through 11th, an Agriculture Security Conference sponsored by the Alabama Department of Public Health, the South Central Center, and the Alabama Department of Agriculture and Industries. And on June 27th, which we had already talked about, the Safe and Sound Children's Conference, keeping children and families safe through sound emergency practices. And as Martha says, you can get more information at the South Central Partnership webpage, which is up on there. And my teleprompters tell me that there are a lot of educational programs being planned over the next several months. We hope you can join us. Don't forget to complete the program evaluation. That's how we understand if we're doing a good job. I want you to have a great day, great afternoon. We'll see you next time. Thank you.